Hi, everyone. Welcome to Good Morning Sunshine. I'm one of your co-hosts, Brandon Lee, alongside Carrie Pena, talking about OCD, obsessive-compulsive disorder.
You know, it's interesting. I talked to our producers about wanting to do this segment because in recent weeks, I've had several different friends who've talked to me about how they feel that they have OCD or they've been diagnosed with OCD. And then I started doing some research. And to be honest, I did not realize how crippling that
Hugely,
could be.
it can be. And
So-
our behaviors, like you may be even asking yourself, like, I think we throw the term around loosely a
Right,
lot. Like, oh, I've got
exactly.
OCD. You've got OCD. Oh my God, I got OCD. This is why I do this, and this, and this.
So we brought in an expert today, and we're so glad to welcome you to the studio, Dr. Bridget Henry, a clinical psychologist and the vice president and co-founder of OCD Arizona. Thank you so much for being here.
Thanks so much for having me.
You know, can you talk first about what OCD is?
I love that you brought up how, it gets kind of tossed around as a term. And I think that it really leads to a lot of misunderstanding. So it's a great question, like what it is, what it's not. OCD consists of obsessions and compulsions. And so obsessions are unwanted, intrusive thoughts, images, urges, and those cause significant distress for an individual. The distress could be anxiety, but it could also be things like shame or disgust or just like a overwhelming, not quite right feeling. And then in order to try to get rid of those thoughts and that feeling, a person engages in compulsions, and those compulsions can be overt, like things we might see on the outside. That could be like hand washing or repeated checking or asking for repeated reassurance from other people. But they can also be overt, meaning like happening internally. You might not know the person's engaging in them. So that might be things like they might try to like pray to themselves a certain way or try to neutralize a thought internally. They might be counting internally, or even just excessive rumination, which is the process of essentially just like chewing on a thought over and over again. So they might be essentially trying to like convince themselves that this thought is not them internally. And as you can imagine, this cycle can be very time consuming. So in order to meet threshold for diagnostic criteria, these symptoms typically take up at least an hour a day, but usually we see it's much, much more than that. And it's significantly interfering with daily functioning. So it's interrupting how they would actually be functioning in relationships or work or school.
How do you differentiate that? Because that also sounds like the definition of like addiction, like sex addiction, food addiction, porn addiction, right? It meets several of that criteria.
Yeah. That's a great question, because I think on the outside, that cycle does kind of look the same, where you have that kind of distress. And so you're doing something to try to get rid of that distress. And there is often that word compulsive that gets thrown around with addiction. But I think, that like, because there's that urge associated with it.
The compulsiveness.
Yeah. With OCD, there really is this, you kind of like this hallmark part of it where the person it's almost like they're afraid that by not engaging in these compulsions or doing something about this thought or this feeling, something really terrible is going to happen. So it's really much more like fear driven. I definitely recommend finding a provider to do the initial assessment that has some training in OCD, like has, some good training in OCD.
Is it so you diagnose somebody, is it more behavioral life changes or is it medication?
Yeah.
What are some of the solutions?
Yeah, great question. So it's short answer, both. So I'm not a prescriber, but research really supports both medication and therapy, and I'll talk about specific therapy. But as far as medications, research supports SSRIs. A lot of times people might need to find one that works for them. So we might be able to trial and error.
Antidepressants as well.
Yes,
the SSRIs,
Yeah, exactly. But I have folks that come to me and everyone has different thoughts on medication. So I think it's really important to be respectful that everyone has autonomy around that. And so if someone's not yet ready to like entertain medication, again, good news is we do have effective treatments. And if you want to try treatment without medication first and then see if you need it. So on the line of treatments, really the most well-supported treatment from the research is cognitive behavioral therapy, specifically a type called exposure and response prevention. Yeah.
They do a lot of CBT training within treatment centers, addiction treatment centers, by the way.
Yeah. So like there's actually like within the CBT.
DBT and CBT.
Yeah. Those are so great. And again, well-researched, very
well-researched. Yeah.
It's very they give you tools, actual things that you can use. Right. And so what's tough though, I think with the OCD treatment is that it's really a specific type of CBT that is best for OCD. And that is exposure and response prevention. That's the one that's shown, across the research to be the most effective. For about 3 decades now, it's been researched and shown to be effective. There's another treatment too that's well supported by the research called inference-based CBT. And so again, you can hear that they're both kind of like, even within CBT, it's its own approach to OCD.
Yeah.
I say that because sometimes providers, unfortunately, might not know what they don't know. And so I have had a number of people come see me that maybe have been in treatment for quite some time. And they're like, but I've been in therapy and it doesn't help. Actually, I feel like I'm getting worse. And what happens is if you're engaged in just traditional talk therapy, or you're doing maybe CBT that's not specific for OCD, you might accidentally be reinforcing the cycles.
Oh, wow.
So this is also why it's so important to talk about effective treatment.
Wow.
Because it's so tough when you have someone that's like, but I've been in therapy. And unknowingly, if you're not trained well to be able to identify different parts of OCD, a therapist even might accidentally be kind of joining in the process of compulsions. And then, of course, then you're going to, feel worse because compulsions ultimately feed the cycle in a way that perpetuates it.
Is there a parallel here to OCD? And Brandon mentioned this before we came to the studio, but perfectionism, because a lot of people are perfectionists and you just want things to be done right. But is there a parallel there?
Yeah, that's a great question. And again, I kind of picture these Venn diagrams, right?
Yeah.
Of like, well, yes, right? And because you can get perfectionism with and without OCD, but you can definitely see it show up in OCD in this way that becomes like compulsive, right? So I'll give you an example of that. So somebody with like a perfectionistic subtype of OCD might engage in a ton of like rereading of emails because of like a huge fear of maybe I sent the wrong thing, or what if I accidentally said something offensive and I didn't know it, or and so like the level though of engaging in like perfectionistic compulsions is it goes way beyond what's even functional, right? And so to the point where like rereading pages over and over and over again, spending so much time on that you can't actually get work done. Or needing things to like be exactly a certain way so that it feels a certain way before you can move forward, right? And I think that's one of the big differences too when you see OCD thrown around as like, oh, I'm so OCD, and in a way that's quirky.
Yeah.
It's so different than the torment that happens when somebody is actually.
Yes.
And I think too, the downfall that it's become such a common language thing in conversation. Oh my God, I'm so OCD. Like, you should see my closet. All my t-shirts are color coordinated. Okay, it doesn't need to be OCD. Like, if it's not debilitating,
just like a nice closet.
It's just like, I like a nice organized closet. But yeah, you say it so conversationally. And I think the downfall to that is that somebody who does have true clinical OCD won't seek help for it because they're like, well, everybody's got OCD somehow.
That's such a good point.
Right?
And
it's so common. Like,
so
my
true.
friend just said they have OCD, and my other friends the other day said they have OCD. So I guess I do too. And they don't get help for it. So maybe I shouldn't get help for it.
Well, we have a lot of throwing around of labels now, just in general, right? I think that we toss around those labels, and OCD, to Brennan's point, is one of them. Yeah.
It is unfortunate too, because you're right. Like that, it not only, kind of like perpetuates that stigma, or it kind of maybe like, overgeneralizes it, but it also, it just actually continues the narrative around what OCD has to look like, right?
Correct.
It's like someone's thinking like, oh, well, but if I'm not like super clean, I must not have it. Or, but OCD shows up in that checking way and I don't have that. I have this like repeated thought of like a sexual image I don't want, right? And so they're less likely to even understand that is OCD, right? And so then, sadly, the average length of from onset of symptoms to actually getting a diagnosis and effective treatment on average 14 to 17 years.
Why?
I was thinking that. Yeah. It's going to be a long time.
These exact
For those reasons. Of just
It's
rationalizing.
so
And that's the other thing too,
rationalizing,
the frontal lobe, right? That's why talk therapy is only so great. It's all frontal lobe. We can rationalize. We could put things into perspective. It's like our frontal lobe is always trying to play tricks on us, and understanding, like diminishing our own traumas, being like, no, you're okay. Or that happened so long ago. It's still not impacting you, right? That's all frontal lobe talk. Whereas we need to go deeper, and we need to actually kind of, better understand, other ways to solve, right? And to help us heal from those things.
Yeah.
But we just constantly are, honestly, that's what we do.
Yeah.
We just diminish our own pain.
Yes.
Like we diminish our own experiences because we don't want to be diagnosed with something either a lot of times.
Or some people just, hey, I can handle this, or I don't have time to go, seek out all of these treatments for every ailment I have in my life. But speak to the fact that if that is the length of time that people are living with this, how freeing is it when you see a patient who comes in? Talk about the transformation that could happen.
Yeah, I love that you brought that up, because honestly, that is why I do what I do. I love what I do. And so because we do have effective treatment, and I get to be, delivering effective treatment, then I've seen such huge changes, amazing changes that, people that go from a state of not even being able to like get out of bed or leave their room because of just how many fears there are even around like their house, to just re-engaging fully in life, then seeing them like go off to school or, do work and or get, married, or just re-engaging in life. So it's really what keeps me going in this, and what keeps me passionate about it is knowing like, hey, there's things that we can do, and I've seen it. And so it is hard work. The treatment's hard work. So I understand why people might even if they know it exists, it's a hard thing it's a hard sell. It's tough, but it's also, I can speak wholeheartedly from experience and being like, it is so worth it, right? Just trust me. We'll be a team in this.
Life-changing. But this as a doctor, a lot of people will go to therapy for maybe a month or two, and then they tap out because it is a heavy lift at times, especially trauma therapy. It is a heavy lift, but if you stick with it and you really are with a doctor who knows the program, knows the how to diagnose first off, and also a treatment plan, and really staying committed to that, the rewards are boundless.
Yeah.
And just as we close out, I wonder if you could just speak, whether it be OCD or any other sort of mental health, ailment that we suffer from. Can you encourage people to at least take care of themselves, their mental health, just the same as they would take care of their physical health?
It's so important. It is nice that I think now people have more of an eye on that, but we have a long way to go. And so I think absolutely just being able to make space in your life for that, and seeing how much that can help, just not only to take care of yourself, but to connect with yourself better, and then ultimately connect with other people better. And it just makes life so much more enriching and so much bigger. So
thank you so much. We appreciate you. And can you share out where people can find out more about your work? Yeah.
So one really great resource that's not mine particularly, but I do want people to know about, is the International OCD Foundation, iocdf.org. They have a provider search there. So wherever you are, if you're looking for an OCD specialist or, to get diagnosed or treated, that's a huge resource. They also have really great resources for family members. So even if you have a loved one that's not quite ready for treatment and you want support for yourself and trying to understand how to support them, that's a really good hub for that too. But then, myself personally, drbridgethenry.com, and then also OCD Arizona has a website, ocdaz.org. And we're hoping to do a lot more community events. We just had a community walk recently where a lot of people with OCD and their families came out. We had over 100 people there.
That's awesome.
Yeah, it was wonderful. Great feedback. For a lot of people, it's their first time seeing anyone else with OCD.
Yeah.
And just to see them all gather and support each other and see that they're not alone.
Awesome.
That's really cool.
Yeah, that's awesome. I'm glad you did that, giving people an opportunity to connect with others, to make them not feel like they're alone and isolated. That's a huge first step, is to not feeling like you're the only one experiencing this. So Dr. Bridget Henry of OCD, Arizona, thank you so much for coming on, having this very candid conversation. Appreciate you.
Yeah, thank you, doctor. And thanks to all of you for watching and listening. This is Good Morning Sunshine.